Well, hello, everyone. My name is Rhonda Fisher, and I am the clinical program lead for the American Hospital Association Team Training Program. Welcome to our October webinar on improving maternal and neonatal safety using evidence-based practice, teamwork and simulation, and quality improvement. We are pleased and privileged to have a host of Houston Methodist brightest minds speak to us today on this subject of critical importance throughout the nation. And I've gotten a sneak peek at their slides, and I'm just telling you, this is going to be a fabulous presentation. We're so glad you joined us today. But before I hand it off to our speakers, I'm going to go over just a few rules of engagement. So, firstly, this is not the right slide. Firstly, let's try that again. Actually, Kara, do you want to take control and find the rules of engagement? There we go. So rules of engagement. So you can access audio by listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. Please note that you are in a listen-only mode throughout the presentation today. I'll be moderating a Q&A session at the end with our speakers. So if you have a question, please do chat them in throughout the presentation. Of course, if your presentation is technical or logistical, we'll answer that in the moment. But if it's for the speakers, just know we'll save that for the end. Finally, please note that this presentation is being recorded, and we'll notify all registrants when the recording is up on our website. Now let's talk about CE. I know you are interested in that. So we're happy to offer free CEs for our webinars. In order to claim your CE credit, though, you need to create a Duke OneLink account. This is a one-time only setup, and my colleague Kara has chatted in those instructions. You can also refer to the email that was sent to you this morning with the attachment. And then following the webinar today, please text VOFDAG to the number that you see on the screen there. And don't worry, we'll share this again at the end so you don't have to worry if you're not grabbing it now. So just want to tell you about a few upcoming team training events. So in person, our fall master trainer course registrations are in full swing, with the next master trainer course being led by none other than our esteemed Houston Methodist team. That's coming right up on October 31st. They still have a little space left, so you're going to want to get on that registration right away. We also still have a little space in our Tulane and our UCLA courses. So again, send in those registrations just as soon as possible to secure your spot. You can access more information and registration links on this slide. Just so you know, we do highly encourage people to attend as a small team if they can, as we've made enhancements to the course to include human-centered design thinking, so you can work with your team and walk away with strategic and tactical plans for your team steps implementation. We also have a bonus webinar coming up on November 15th, sponsored by Relias, Strategic Onboarding, Maximize Employee Retention from Day One. And of course, that is an ongoing issue across the nation from now, continues to be rather, so you're not going to want to miss that either. All right, so lastly, if you're interested in a customized training solution, we offer on-site trainings where we from AHA actually come to your organization to deliver anything from a 2-day Team Steps Master training course to a comprehensive training program that spans multiple trainings, virtual coaching, etc. So we can truly support your Team Steps implementation efforts to foster ownership and sustainability at your organization. So with those customized trainings, we get to come on site and customize that training just to you and your hospital or health system's needs. So you can visit our website to learn more about that, complete a brief questionnaire, and one of our team will get back to you ASAP. So with that, I'm going to turn it over to our presenters today. So happy to have each and every one of you. Thank you for joining us. We're so excited to hear from you.
Thank you, Rhonda, so much. Thank you for having us here. We're actually also excited to be here and present this to you today on improving maternal and neonatal safety. We recently presented a similar version of this at our own Houston Methodist Patient Safety Symposium in the Medical Center here in Texas, and thought this would be really appropriate for an AHA webinar as well. We hope you agree. This presentation combines two great passions of ours, this whole panel, and the Houston Methodist system, and that is high reliability and women and infants health. We have a wonderful panel of speakers for you here today. I am personally so proud to work with each of these colleagues, all of whom are involved on so many levels, local, county, state, and national. But I think they would all agree with me that the improvements that we have made together and have yet to make are richer, stronger, and more powerful by our collaboration and teamwork, not only with each other as leaders, quality providers, but also with our local hospital administration, our system leadership, and perhaps more importantly, or most importantly, in high reliability fashion, with our frontline staff, as you will hear from each of us today. I'm Dr. Stephanie Bruce. I serve as the Assistant Chief Quality Officer at Houston Methodist Willowbrook Hospital in Houston, Texas. Sharon Padagok is our Houston Methodist System Senior Program Manager for Women and Infants Health. We will share more with you about our hospital and system, along with the framework we've created for quality and safety improvement a little bit later on. Dr. Domino is an OB hospitalist who is the medical director of operations with OBHG, overseeing 21 maternal programs across the United States. And she is our Houston Methodist Willowbrook maternal medical director and is also on the National Board of Directors of the National Society of OB Hospitalists organization, in addition to being faculty for Texas AIM here in the state of Texas. Dr. Stacy Norton is our Houston Methodist Willowbrook Chief of Staff, and she's instrumental in leading our Team Steps training and simulation initiatives locally and across our system. She's also AHA faculty and is leading this initiative across our nation. I highly recommend bringing your local hospital team to one of the 2-day Team Steps master training courses that Rhonda just spoke about that AHA offers. And then we have, last but not least, Atish Arunachalam is our Houston Methodist Willowbrook Neonatal Medical Director, as well as the Associate Medical Director of Community Initiatives with Texas Children's Hospital System. And he's also faculty for Baylor College of Medicine, Texas A&M School of Medicine, and Texas Children's Hospital, where he has won numerous prestigious teaching awards. Sharon, do you want to start us off and just tell us a little bit about the Houston Methodist system?
Yes, thank you, Dr. Bruce. Houston Methodist is just over 100 years old, having started during the global Spanish flu pandemic. You might recognize us as the hospital system that was first to require vaccination of our employees during the COVID pandemic. We are a growing seven birthing hospital system, and we're very excited to open our 8th hospital in the next 18 months. We provide both level 2 and level 3 neonatal and maternal care, delivering about 15,000 babies each year throughout the greater Houston area. COVID brought many changes to healthcare in general and the way we work in the hospital. The necessary rapid cycle changes helped us to realize that we needed to modify and expand our system leadership, bringing our maternal and neonatal medical directors to the table with our nursing leaders. Not only that, we had to find a way to effectively share and disseminate information across our system and throughout our entities, so each hospital team would not have to recreate the wheel every time we encountered an issue that needed improvement. But I'm getting ahead of myself. We'll discuss our framework toward the end of this presentation. Dr. Bruce, why don't you tell us a little bit more specifically about Houston Methodist Willowbrook?
Yes, Houston Methodist Willowbrook is one of our system community hospitals. We're a 350-bed hospital and have a level 3 maternity unit and do over 3,500 deliveries a year, the most of all the hospitals in our system. Along with this, we have a level 3 NICU as well that is also the busiest in our system. We're a Texas 10-step designated facility as well as a breast milk donation site in the state of Texas.
Before we get to our expert panel from this hospital, let's discuss the State of the Union, so to speak, about healthcare in America, and more specifically, the state of maternal and neonatal morbidity and mortality. I've been a labor and delivery nurse for about 15 years, and Dr. Bruce, you did obstetrics and gynecology in private practice for nearly 20 years. I think we were both a little unaware about how America as a whole has been performing.
Oh, most definitely, Sharon. I still remember I was at an ACOG district conference nearly a decade ago now when I heard a mentor of mine, Dr. Patricia Shulock, give an ethics talk on wellness. Not only was she talking about physician wellness, but she spoke about the wellness of our nation and specifically the quality of healthcare in America. She shared some studies and evidence about medical errors being potentially the third leading cause of death in the United States, just behind heart disease and cancer. This did not sit well with me since one of the main tenets of being a doctor is primum non nocere, first do no harm. Then she showed the maternal mortality statistics in America that were already well above and rising compared to the declining and lower maternal mortality in other developed nations. I had no idea. I sat there in shock and disbelief. I had been practicing for over a decade. And so I began to wonder, how did I not know this? Was I contributing to this? What could I do to change this? And searching for these answers set me on a different career trajectory.
The neonatal mortality statistics are no better. And you bring up a great point, Dr. Bruce, and that's why we feel so passionate and compelled to share this information with everyone. How many other healthcare providers in America are simply not aware of the outcomes that our American mothers and babies experience compared to those mothers and babies in other developed nations? There's been some publicity around this as well. A few years ago, Forbes, which recently listed Houston Methodist as one of the best employers in America, had an article about maternal and infant mortality, and they titled it Signs of Public Health Neglect. And I agree with that. There are huge social disparities, difficulties in accessing care, and many untreated chronic disease conditions in our nation that all contribute to our mortality rates.
I completely agree, Sharon. And there are so many efforts around these issues that are now finally starting to gain some traction to try to improve this. Today, however, we're going to focus on what can be done in our acute hospital settings to improve outcomes of patients who walk through our doors. In recent years, we have really just continued to worsen rather than improve in our morbidity and mortality outcomes. Most appalling to me with regards to maternal mortality is not only that we are the worst compared to other developed nations, but just how large of a gap we have. This is some of the most recent data available from the CDC showing we're now nearly 3 times the rate of the next developed nation below us, and over 14 times the rate of the nation with the best maternal mortality rate. It's truly painful to see this data.
It really is. It's always hard to see these graphics and statistics for me as well. But there's some great work being done to turn the page toward a better trend.
Yes, you're right. And California actually has distinguished themselves as a state in our nation, making a difference on maternal mortality as early as 2007, and a trend they have continued. They've done this through the establishment of what's called the California Maternal Quality Care Collaborative, a multi-stakeholder organization established in 2006 by Stanford University School of Medicine and the state of California to end preventable morbidity and mortality and racial disparities.
Then ACOG partnered with the Health Resources and Services Administration to establish the Alliance for Innovation on Maternal Health, or AIM, at the national level in 2014. National AIM currently houses 8 core maternal safety bundles. And as of May 2023, 49 of our 50 states have enrolled, starting the process of implementing one or more of these bundles. Here in Texas, we established the Texas Collaborative for Healthy Mothers and Babies and are committed to learning from California and other states' collaboratives while incorporating our own initiatives to reduce maternal and neonatal morbidity and mortality. The Texas Department of State and Health Services has implemented a mandatory survey for both maternal and neonatal levels of care designation, and also successfully lobbied to extend Medicaid coverage for up to 1 year postpartum, really optimizing access to postpartum care. Texas AIM chose to focus on 3 of the 8 national AIM maternal safety bundles that were assessed to be the most impactful to our Texas mothers. And our Texas AIM initiative to reduce severe maternal morbidity in the space of obstetrics hemorrhage saw much success. And we continue to work impacting the families affected by severe hypertension in pregnancy, hoping to permanently change the landscape of Texas maternal morbidity and mortality. The focus from the state and other regulatory and consumer agencies, combined with the safety bundles, are truly making a difference at a state level.
Yes, and now it's up to us at our own institutions to take this forward, first at a high level and then to the frontline staff. So let's talk high level first. The concept of high reliability that we hear about in our airline and space industries is now really permeating into healthcare. At Houston Methodist, as a system, we use the tenets of high reliability in our work to decrease maternal and neonatal morbidity and mortality. Today, I want to highlight 3 of these that are most applicable to this topic. First is a deference to expertise. And this means using evidence-based medicine and best practice recommendations to decrease variability and improve outcomes. Second is using high performance practices. This includes exceptional teamwork and standard communication, such as that taught in team steps, and simulation to practice low volume, high risk events to give healthcare workers both competence and confidence. And third, we must continue the continuous process improvement because there's always work to be done. Perfection is rarely achieved, and the best people to lead any quality improvement is almost always the frontline staff. I'm so excited for you to hear how our panel has been able to promote and implement these 3 elements of high reliability organizations. So let's jump in and hear about some of these.
It is my pleasure to introduce our first panelist, Dr. Rocky Domino. She serves as our Houston Methodist Willowbrook Maternal Medical Director and is an active member of our Houston Methodist System Women and Infant Council. She is helping lead locally and within our system to improve patient safety and quality outcomes through decreased variation and implementation of evidence-based best practice.
Thank you so much, Sharon and Dr. Bruce. Practice patterns in maternal care vary greatly between providers, facilities, and actually geographic areas. For example, C-section rates in full-term, first-time mothers with a baby in the correct birthing position varies greatly between U.S. regions. For many years, the Pacific Northwest has had one of the lowest rates, while the South has had one of the highest. The standard of care should not be established simply by how others practice in your geographic area. Standard of care should be established by relying on the best available evidence to support practice decisions. In fact, implementing evidence-based protocols has been shown to significantly reduce maternal mortality. OB Hospitalist Group, a national group of OB-GYN hospitalists that employs more than 1,500 physicians and midwives, including myself, has been working to reduce their C-section rate in first-time mothers with a term baby in vertex position. This is called the NTSV rate and is a national metric with a standard definition. Like national data, OB Hospitalist Group's NTSV rates were higher in the South than in the Pacific Northwest. They implemented an evidence-based practice at one of their hospitals in Texas to try to correct for geographic differences in practice patterns. This team used a pre-C-section checklist based on nationally published evidence and recommendations of the California Maternity Quality Care Collaborative. The checklist still allowed the delivering physician to make their own decision on when to do a C-section. It, however, made the physician more aware of when their decisions varied from evidence-based recommendations, and thereby decreased variation that was not based on evidence. This group drove down their NTSV rates from above national averages to below the national average. As a large national group, OB Hospitalist Group was also able to decrease its national NTSV rate below national averages. Importantly, the group was also able to demonstrate similar NTSV rates even when broken down by race and ethnicity. Reliance on evidence-based medicine can be a significant way to decrease racial and ethnic disparities in maternal health. Others have been pushing for the use of evidence-based clinical protocols for pregnant, delivering, and postpartum patients. As Sharon said earlier, ACOG developed the Alliance for Innovation on Maternal Health, or AIM, in 2014. This is a quality improvement and safety initiative that uses evidence-based patient safety bundles called AIM bundles. Texas AIM supported hospitals across the state of Texas with implementing the hemorrhage and pregnancy bundle. The statewide initiative urged hospitals to use evidence-based protocols to assess for hemorrhage risk in pregnancy, quantify blood loss associated with delivery, and use stage-based management to treat hemorrhages. It also included ensuring appropriate medications to treat the hemorrhages and massive transfusion protocols were readily available on each unit. More than 98% of birthing hospitals in Texas participated in this initiative. This accounted for more than 99% of births in the state of Texas. And actually, because Texas is such a big state, it included 10% of the births in the entire United States. Prior to the statewide implementation of this bundle, morbidity and mortality had been rising each year for many years, as you can see in this graph. With the implementation of the bundle in about 2019, the morbidity related to hemorrhage has been decreasing over the last couple of years, shown in the dark blue line. For the first time in probably a generation, we have successfully pushed maternal morbidity related to hemorrhage downward in our state, and it was by implementing evidence-based practices in many of our hospital units. Using the framework and support of Texas AIM, Houston Methodist Willowbrook Hospital has been implementing the hypertension in pregnancy bundle. Like many hospitals in the state, we have implemented an evidence-based protocol to ensure that pregnant and postpartum patients with hypertensive emergencies in our hospital have timely treatment with appropriate antihypertensive medications. This is incredibly important because blood pressures greater than 160/110 in a pregnant or postpartum woman carry an increased and real risk of stroke that can cause permanent paralysis or even death in the mother. These are often young women who have many years of life ahead of them, but they can no longer really be the mother that their family needs. Prior to starting this initiative, we studied our barriers to timely treatment. These included physician preferences or adherence to older recommendations of when to treat blood pressures instead of current evidence. In other words, sometimes our decision on how and when to treat a patient were not based on evidence. With implementation of this protocol on our women's services units, we were able to increase our percentage of patients treated in a timely fashion from about 30% to above 90%. As we initiated this protocol on our women's services units, we realized that this protocol could not be isolated to women's services. Pregnant and postpartum patients are being seen in our main ED, medical surgical units, ICUs, and the main OR. This is an important perspective for those of you who are not in maternal care. Just because a woman is pregnant does not mean she will not have health issues that require her to seek care outside of your women's services units. The advantage of using evidence-based protocols is that they can be used to create an easy-to-follow algorithm for those who do not routinely treat pregnancy and pregnant patients. Likewise, when non-maternal units implement evidence-based protocols to treat non-OB medical issues like sepsis or respiratory distress, we need to make sure that pregnant and postpartum women are not excluded from the protocol. Exclusion from these protocols lead to a wide variation in how pregnant and postpartum women are cared for and poorer outcomes in these women. After the success of the hypertension protocol, Houston Methodist Willowbrook developed a best practice committee. We believe that this committee will be essential to the continued implementation of evidence-based care at our hospital. It has representation from each OB-GYN practice group, nursing, department leaders, neonatology, anesthesia, and our hospital executive team. The committee is tasked with reviewing the available evidence around an issue that is a key goal for our hospital or identified through our case reviews. Examples include reducing length of stay for mom and baby, reduction of readmissions after the delivery episode, of course, NTSVs, and first trimester complications. After careful examination, a consensus is reached on practices that can be implemented across our department to improve outcomes for the women and babies we care for. The goal is to make sure that we are relying on evidence to guide our care and reducing unintended variation. For too long, we've allowed the use of varied practice styles based on individual or regional preferences in maternal care. We know that reliance on evidence-based protocols that minimize variation decrease maternal mortality and morbidity. Evidence-based medicine may also improve racial disparities in maternal care. I urge those of you in areas that are not directly related to not directly related to maternal care to consider this as well. Make sure that pregnant and postpartum patients are not left out of your normally accepted evidence-based protocols. Instead, let's consider together how we can implement evidence-based protocols for pregnant and postpartum women, no matter where they're accessing care.
Excellent, excellent, Dr. Domino. Thank you so much. Your perspective and leadership are making a difference. Next, we have Dr. Stacy Norton, our current Chief of Staff at Houston Methodist Willowbrook, who's been leading and teaching team steps at Willowbrook and across our Houston Methodist system. She's been a key leader, along with you, Sharon, in developing system-wide simulation training for all of our entities. She has seen firsthand how training and communication that is appropriate and has common vocabulary, along with simulation, can improve outcomes in patient safety and quality. Thank you for joining us, Dr. Norton.
Thank you, Dr. Bruce. Next, we're going to discuss team training and why team training is as important as evidence-based practice and continuous process improvements. Team training is the foundation and the glue between these two. It promotes the culture on our units that allows us to implement the ever-evolving best practices and to carry out our continuous process improvement projects. Team training is vitally important to healthcare because none of us take care of our patients all by ourselves. Medicine is a team sport, and you need your team for all of your patients' care. But there's one fundamental problem with healthcare education. Historically, it has been very separated. Doctors attend medical school, nurses go to nursing school, pharmacists to pharmacy school, and so on. We complete our education and arrive at our new jobs ready to go with the most up-to-date knowledge on day one, but we are with people that we've likely never met, nor do we know their exact roles and responsibilities or even speak the same language, and we are expected to act like a high-performing team. Unless you're a very recent graduate, you most likely have had absolutely no team training. In our facilities, we have expert healthcare providers from ones that have been practicing for decades to ones who just graduated in July. However, our patients need and deserve our team of experts to perform like an expert team. So how do we do this? We have a continuous twofold approach: team steps and simulation. Team steps is an evidence-based set of teamwork tools designed to optimize team function and improve patient safety. Although it's been used in healthcare for years, our hospital started formally educating and using these tools in 2018 in preparation for our first maternal leveling survey that occurred in June of 2020. It is our framework for team structure and communication and all patient care. As I often say, team steps is not something new to learn, but how we do everything. Second is simulation. Frequent simulation on our unit allows us to practice many things: newly implemented best practices, teamwork and team steps communication tools, and it builds trust and familiarity with our unit members. And mostly important, it allows us to practice in a low pressure and safe environment our high risk events, such as hemorrhage, shoulder dystocia, and hypertensive emergencies. Low frequency and emergency events also are simulated, like maternal codes and amniotic fluid embolism. When we started our team training journey, we started with the basics. What is team steps? We defined it and explained how we are much like other reliability organizations like the military and the aviation industry. We began our training with a badge buddy and simple communication tools. And every physician at our hospital that has OB privileges is required to participate. We started with SBAR, situation, background, assessment, recommendation, and request. We explained that this is the clear and concise way of communicating critical patient information when the conditions change or a new person presents themselves to the healthcare team. We then focused on briefs and debriefs, and these are now the basis for our twice daily safety huddles regarding our high-risk maternal and neonatal patients, and now we debrief after every single delivery. The goal is also to include the patient and her family in this debrief process. In our simulations, we also teach situational monitoring and a shared mental model, which in our case is always the safe delivery of a baby and a healthy mom. Our team training has improved trust between physicians and nursing staff, and simulations and drills have improved our response times and our patient outcomes. Our success often encourages and begets more success, and it is truly an aha moment when, after simulating an event, a few days later, the real situation occurs, only this time it goes so much better. After teaching the basic tools, we reinforce the concepts with simple, non-medical simulations, and we train all of our persons on the unit together. Physicians, nurses, midwives, PCAs, unit secretaries, environmental services, everyone trains all together, not separately. And we use simple items like paper, marshmallows, spaghetti Legos, Mr. Potato Heads, things that are not expensive and very easily to port to our day shift, night shift. These tools level the playing field and make this education somewhat fun. At first, people are hesitant and not sure, but then the competitive side of all healthcare personnel comes into play and the challenge is on. In these photos, you can see us using our Mr. Potato Heads, our paper chains, and our Legos for our concept solidification non-medical training. Now we're getting to the meat of where we are now. We use low and high fidelity simulations on a regular basis. We also do basic refresher courses on team steps and communication, especially on our night shift where our newer nurses and newer personnel are that need to work on their communications. But we also do regularly scheduled low and high fidelity simulations on our unit. For our low fidelity simulations, we use our Mama Natalie, which is here in the bottom left corner. This is a belly, placenta, and a baby that one of us wears. In the middle picture on the bottom, you can see us actually doing one of our simulations this summer. You can see our midwife is actually wearing our Mama Natalie. The OB hospitalist is delivering, and we are simulating our urgent requests to our OB hospitalist about a shoulder dystocia occurring in our low intervention birthing suite. Low fidelity simulation is not expensive and it's flexible. You can't always do your sims when you plan to do them. And they're done on your unit in situ, where you learn processes and improvements that you need to make on your exact unit. For instance, where is the hemorrhage cart kept? What are the barriers to getting it to where you need? Does everyone know what's in every drawer? And has everyone met our newest OB hospitalist? Next is high fidelity simulation. On the other hand, it is equally important, but very different. Not everyone has the resources to or is located near a high fidelity sim lab. It can be quite a bit of money to attend, and you have to send your participants away. However, the rewards are very much worth it. There you train your trainers, and you have an expert team return to your unit with new knowledge, skills, and hopefully more enthusiasm to continue this team training. We just last week did a 2-day training at our simulation lab at Houston Methodist with 2 of our hospitalists sending a team each with a neonatologist, an obstetrician, pharmacy, nursing staff, etc., who learned to write and create and execute high fidelity simulations, and then we practiced our debriefing skills. They are bringing those back to their community hospitals. And back at our Houston Methodist Community Hospitals, we work on our units with our unit-based educators and our physician leaders to create a continuous cycle of simulations that occur multiple times a year. These occur on both the day shift and the night shift to keep the training sustained. This has built a culture, such a culture of safety on our units that has been essential to our success.
Thank you so much, Dr. Norton. As somebody who's run sim with and without that training, it was invaluable to be able to have that education last week. So really appreciate that and want to echo the worth that high fidelity sim and specific training really lends to your practice. Next, I want to welcome Dr. Arunachalam, or Atis, as he likes to be called. He is the neonatal medical director at Houston Methodist Willowbrook, and under his leadership, they recently had a level 3 NICU survey with 0 deficiencies. He has led this NICU to achieve some of the highest neonatal quality outcomes in our Houston Methodist system.
Yes, and he does not do this alone. Sharon, if you want to advance the slide so we can show Atish, but he enjoys teaching medical students, but he also enjoys teaching the nurses that he works with on the unit. And his secret is his commitment to teamwork and quality improvement projects. He leads a protocol-driven unit of best practice, like Dr. Domino discussed earlier, but he has not only led dozens of quality improvement projects himself, but he has supported his nursing and his medical staff and even medical students in their own projects as well. His ability to empower his staff to invest in quality improvement and own it themselves is unparalleled, and I am excited for him to share with you how he has done this.
Thank you, Dr. Bruce, for that introduction. It's truly an honor to be here and have the opportunity to share some insights and experiences with all of you. Over the years, I've had the privilege of working with outstanding students as well as dedicated nurses in the neonatal ICU. One of the secrets to our success in delivering high quality care has been our commitment to teamwork, as you mentioned, and the pursuit of excellence through QI projects. Here in this slide, we have listed some of the QI initiatives in the recent years, and many of them have been either led by nurses or lactation therapists or physical therapists. So over the years, we have not only initiated numerous projects, but have also fostered a culture where our nursing and med staff are empowered to lead their own initiatives. And you mentioned about evidence-based protocol. We have no other option. If we need to standardize care, that's our only option. In this slide, I just wanted to highlight our 4 major areas that we focused on to make quality improvement a fun experience in our neonatal ICU. So, NICU can be a highly intense environment, as we are not only taking care of sick premature infants, but also anxious and extremely worried parents. The first thing for me as a medical director was to ensure a friendly environment to make sure it exists between our physicians, nursing staff, and the nursing leaders. It's not rocket science. People are always more comfortable when work colleagues are friendly. This change in work culture, resulted in more staff willing to bring up issues and some great ideas to make things better. The next one was to make sure we utilize data and metrics to make informed decisions, monitor progress, and ensure that quality improvement are based on evidence and outcomes. Third, for us was to establish a culture where staff embraces the idea that quality improvement is an ongoing process, not a one-time effort. We had to drill down the fact that we all have 2 jobs as healthcare providers. One is patient care and the other is quality improvement. Finally, physicians and colleagues should provide timely appreciation to the staff, irrespective of their role, whether it's big or small, and have a way to incentivize them. You can have them present in conferences, sponsored to go to meetings, give them authorship, make posters, etc. This is how we started our QI journey with the vision of converting a community newborn ICU into an academic unit. At the end of the day, if the staff feel comfortable, valued, and respected, participating in a quality improvement initiative becomes a positive experience for them. In this slide, I'd like to share with you an impactful example how a nurse's suggestion led to a significant improvement in our healthcare system. It all began with a concern raised by one of our nurses. She noticed that her staff were frequently pulled away from their patient care duties multiple times a day to perform a manual double check to ensure that the right mother's breast milk was given to the correct baby. For us in the NICU, administering milk is like administering medicine, so we do not want to make any errors. Initially, when she came up with that response, with that question, I, like many others, thought the current process was good and that manual double check added an extra layer of security. After all, it was being conducted alongside our existing barcode scanning procedure. But as a result of that question, we did a literature review and we took a deeper look at our entire breast milk collection process from the moment it was expressed by the mother to its storage, administration to the baby, and everything in between. This slide has a simplified version of the process map we created. Basically, milk is received from the mother and deposited in the milk room in the NICU. The patient nurse adds fortifiers into the milk in the milk room, and the prepared milk is transferred into different containers, ready to be used for every feeding. This milk preparation happens once in 24 hours. A patient nurse administers the milk to the baby when it's time. Prior to administration, the nurse scans both the patient's wristband and the milk container, and also must get an independent check from another nurse in the unit. Here's what we discovered. There was no double check at the critical point of mixing breast milk in the milk room. We had two checks in place, barcode scanning and a nurse verification. But the second independent check for breast milk was redundant and did not add value. We realized that the potential for error was greater during the mixing process than during the administration process. To validate our concern, we collected data and found several near-miss events in the milk mixing process. Armed with this information, we made a crucial change to our process. We introduced a double check during the milk mixing stage, which was done once in 24 hours per patient, and consequently, we eliminated the need for nurses to perform the double check before administration, which was actually done at least 8 times in 24 hours per patient. So if you have 10 babies in the unit, you're talking about 80 times a nurse is pulled away from her own, taking care of her own patients. So we continue to use barcode scanning, which is sort of the gold standard as a primary verification method. Next slide, Sean. Yeah, this process, what happened, it led us to investigate how many independent checks are we doing on medications. Prior to March 2020, breast milk feedings and almost all neonatal medication administrations require 2 nurses' signature for verification in the NICU. Most NICU medications are sent as a unit dose by pharmacy. They're not drawn up or mixed by NICU nurses. Routine oral medications like vitamins and skincare products are low risk, but they were subject to the same independent double check process. If you look at the graph here and the pie chart, pre and post intervention, the percent of independent double check went down from 85% to 21% after we started this intervention. This change not only streamlined our workflow, but also significantly reduces the chances of errors in administering breast milk to our newborns. This was discussed in our Houston Methodist System Women's Council, and this process was approved for all hospital works across the system. The nurse who brought up this idea was recognized. She was able to present a project in a magnet conference. So with this, I would just like to end by saying this project was a testament to the power of listening to our frontline staff, being open to reevaluating your process, and ultimately improve patient care through data-driven decisions. Thank you, and I yield back.
Thank you so much, Dr. Ortiz. You're an inspiration to us all.
Oh, and I agree. And thank you all, actually, Dr. Domino, Dr. Norton, and Dr. Ortiz for sharing how you've employed these high reliability habits and of deference to expertise, using high performance practices and continuous process improvement with the frontline staff in our hospital, our system, also at the state and national levels to make a difference in maternal and neonatal morbidity and mortality. At the system level of our hospitals, we realized that we did need to make some changes. During COVID, we had a women's council that had a nursing leadership representation from each hospital entity, but only 1 or 2 physicians. We quickly realized we needed to bring all the maternal and neonatal medical directors to the table. We recognized the need for some system quality and patient safety oversight, someone who could be a bridge between all of our hospitals. We worked with system quality to get Sharon's position of program manager approved. And Sharon, you came and hit the ground running.
Thank you so much. It certainly helps to have great partners throughout the system. When my role started, I signed on to help the hospital teams implement and sustain the maternal safety bundles, as well as help collect and validate data being newly reported to outside agencies. I discovered very quickly we have amazing teams at each of our 7 campuses. Unfortunately, they were all working in silos. All teams participated in Texas AIM and were implementing each element of the safety bundle as individuals. Being the system representative, I was able to bring all the entity AIM teams together into a collaborative. Together, we discussed how we could work together to systemize and the structure and process measures of the safety bundle. Having been an educator at one of our entities, it was important to me that the educators were also able to work as a team and decrease some of the redundant work that was happening in that role. This year, 6 out of 7 of our hospitals had their maternal designation survey. And with 5 new maternal program managers, it was imperative to bring that group together to build camaraderie in a stressful role and work more effectively as a team, building on everyone's individual strengths. The NICU Manager Collaborative functions in much the same way, as many of our operations managers currently split their role and function as the program manager as well. All of these collaboratives now report up to the Women and Infant Council, which is a long-standing system committee that has evolved in the last year. Last year, we carved out time, brought together the leaders, and to evaluate the effectiveness and strategically plan for the future vision and goals of the System Council. We identified gaps that knowledge was being disseminated at the Women and Infant Council, but it wasn't always reaching the bedside providers. Thus, we expanded our attendee list even more to include operations managers, program managers, and educators. We expanded the meeting from 3 to 6 hours, set some recurring agenda items, and I started reporting out the Women's Quality Dashboard, which houses quality metrics from all kinds of different agencies. And we used that to discuss how we could use our quality information to drive impactful change. The System Council then reports to the System Chief Nursing Officer Council. In addition to the creation of these collaboratives and council reporting structure to promote our service line level initiatives, Dr. Bruce and I also raise awareness of quality improvement opportunities at a system leadership level. We represented Women and Infant Council at the System Quality Strategic Planning session, successfully lobbying to obtain our first ever system-wide maternal strategic quality goal. The structure has also resulted in more effective spread of teamwork, quality initiatives, and process improvements like the ones you heard about today. We use this framework to continue to identify and impact the processes that our Houston families need most. Our most recent project has us building on our collaborative framework to partner with our emergency departments for an improved plan to co-manage the maternal patient presenting to the main emergency room with first trimester bleeding.
Yes, thank you, Sharon. We're so grateful for your leadership so we can effectively implement these safety bundles, evidence-based best practice, and process improvements in managing maternal and neonatal patients across our system. We have found this framework to be very solid as we collaborate from the system level down to the frontline staff in all of our hospitals across the Houston area. I am especially grateful to the local leadership that we've had at Houston Methodist Willowbrook with the presenters you heard today. And I'm grateful for what they have done to lead our decreased variation, improve our best practice, team steps, and simulation training and quality improvement initiatives. We hope that you have enjoyed this presentation as we have enjoyed preparing it for you, and we are all happy to answer any questions that you all may have. Thank you so very much for having us today.
Thank you so much. What a phenomenal presentation. I have a ton of questions, so if y'all don't start throwing them into the chat, I will just monopolize the next 10 minutes. I'm just saying. So let me start with one I see Dr. Domino started to address that in the chat, but it'd be great to hear it out loud. Would anyone care to comment on the value of sharing performance data in a transparent fashion in terms of changing behaviors for both physicians and nursing staff?
So I'll start
several
with
of you to weigh in there.
Yeah, I'll definitely start with that one. You know, many hospitals have used different ways to share their data, either individually or in a large group. So sometimes with individual scorecards that are mailed privately to physicians, or in a public format on a bulletin board where everyone can see everyone else's data, or in a department meeting. That can be useful for some. I think overall, human nature, you want to do better, right? You don't want to be the one in red. And so for some people, it really does drive improved metrics. However, some of your toughest people may not even care what their metrics are. And they will say, we have, I've always taken good care of my patients. I haven't had any lawsuits. My patients love me. Why do I need to change just to meet your metric that you happen to be following? And so I would be cautious about that. We see this a lot with NTSVs, and maybe a more beneficial way of doing it is not just with their metric, but actually reviewing their charts and having standard protocols that you're reviewing it against, and then taking it to that person individually and showing them how their choices and how they took care of their patient may not line up to best practice protocols that you have. And that may make a difference, because ultimately that doctor still and nurse still want to do better for their patients overall. They want to take good care of their patients. They want that good feedback from their patients as well.
I'll just tag on to that too. I thanks for calling out about the nursing staff. Historically, I don't think it's been done that much. From our system perspective, we do some of each. Some of our sites have not unblinded their data yet. They maybe don't even discuss it yet. Some give that physician scorecard, and others have been doing those two things. So they've moved on to unblinding it in the department meeting or a bulletin board type of a situation. And now they're really starting to look and to try to correlate the nursing staff's rates as well.
And I'll just add a little bit more to that too. I think when you talk about data, we can talk about us as a system. We can talk about each of our hospital entities, and you can get down to the individual level, nurse and physician, as Sharon and Dr. Domino have shared. At Houston Methodist, we participate in Vizient. A lot of the academic medical institutions across the United States also participate in Vizient. Vizient doesn't have a ton of maternal data and comparisons, but there are several metrics, and that is on our quality dashboard that Sharon mentions that we share, that we look at comparatively within the system, each of our hospitals compared to each other, but also where we fit in nationally. How do we fit in on a national benchmark? We look at things like NTSV that Leapfrog uses and US News and World Report uses as publicly reported measures. Now CMS is looking at that as well, because there is a national benchmark, there is a national rate there. And so looking at individual physicians and nurses with that, we do think that transparency is becoming more important, because quality data is becoming more important transparently across the United States. And so, as Sharon mentioned, not all of our hospitals, we're still growing, and these are growing pains, really, I would say, are struggling with this. How to become more transparent with our data at a hospital and system level, and how to be transparent at an individual level. That gets more painfully real for people. But what's been good with having Sharon in her position is we have been able to compare ourselves to hospitals, hospital to hospital. How's Willowbrook compared to Baytown and Clear Lake? And we can share some best practices, and that has been helpful. And we are working towards becoming fully transparent, even at an individual level.
Yeah, I'll just make a couple of comments. I put in chat box some of the articles that talk about quality improvement dashboards. The number of articles about QI dashboards, which actually it's a display platform, has gone up in the last few years because people started seeing the value of making data transparent. With increase in use of electronic medical records, if you sit down, if you have EHR, you sit down with informatics team and work towards a way that you can pull some important information into a dashboard way, and you show it out. Once you display the data, displaying data itself is quality improvement. Even if you're not planning to do anything with it, at least some people over there, because competitive nature is common among people, so they'll start showing some.
Great. Gosh, thank you so much. Of course, as the team training clinical lead at the AHA, I've got to come back to Dr. Norton. And you said something that I feel was so profound. Team training is the glue between evidence-based practice and, I believe it was quality improvement. Was that the second piece of that? So will you speak to that more, Stacy? And perhaps you could add to the conversation that we just had about metrics and quality measures and how you're seeing your simulation training and adding team steps to that piece of it, how that's impacted your metrics, or how you're seeing that team training practically become the glue for you between evidence-based practice and quality improvement.
Thank you. So team training is actually the way that you get it done. So by training everyone together, we get our staff together, doctors and nurses, unit secretaries, everybody trains together so they get to know each other. They build trust with each other. So also they realize that once we practice things, I have a medical degree and I've been practicing for X number of years. I know what I'm doing. But then when I do something as a group, I see how our team is needed for the care, how teamwork can improve my crash cart getting here on time, my hemorrhage cart getting here on time. We know where the supplies are because we've just run and gotten and done them. We've now interacted with other parts of the hospital. We do team training in collaboration with our ER, with our ICU. So we now have better handoff for our patients, right? We have better teamwork all the way across. And now that we know each other and we feel comfortable with each other and we're working well with each other, we see improved time responses, outcomes, those kind of things. And then when you see your team doing well, everybody wants to be on that team. Everybody wants to keep making improvements, right? Success begets more success.
I just want to play that recording over and over. Wonderful. I know we're drawing to a close here. One of the things that I just want to commend you, your team is doing. So I'm a nurse. I've been an ER nurse actually for over 3 decades. But what I love about your panel and your focus today is your truly interdisciplinary approach to both evidence-based practice and quality improvement. And what I hear from you, even as you talk about like your quality metrics and transparency, your nurses have to be walking away feeling confident and competent and empowered by the type of team and the way that you're embracing team as a multidisciplinary unit. So hats off to you, Houston Methodist. We appreciate you leading the way, not only in our quality metrics and our how we're pushing to improve maternal and neonatal morbidity and mortality, but also for how you're leading the nation in team training. So that's all we have for today. Last slide, just to remind you, if you want to go forward, Sharon, we'll just show them that. Last slide on CE. Don't forget to please fill out your evaluation forms that will appear on your screen once the webinar ends. And then don't forget, you'll want to create that Duke OneLink account if you haven't done so yet, and text that BOFDAG to that number within 24 hours, and you will indeed get CE credit for our time here today. I know a number of people were asking about the recording. I'm so happy to say, yes, we do have this recorded. So please do pass it on to your teams. And thank you everyone for joining us today for this wonderful presentation. And I'm confident that we're going to make strides across the nation in this important topic. So thank you again, everyone, for joining us, and have a great afternoon.